Assalamu alaikum. This is Dr. Rahman. Welcome to all of you today's masterclass on heart failure management. Today we'll cover pathophysiology of heart failure as our lecture one. As we know, heart failure is a very common and progressive disease, and we also know heart is a very important circulatory organ. Heart failure happens when heart does not pump properly and fail to distribute oxygen-rich blood throughout the body, and lots of symptoms happen in our body. As we know, heart failure is going concern issue in our country as well as world. So today our topic is heart failure management. And let's welcome to our presentation our honorable speaker, Dr. Muhammad Shafiqur Rahman Patwary. Dr. Shafiqur Rahman Patwary is a very eminent clinical and interventional cardiologist in our country. He is working as a associate professor, cardiology department, National Institute of Cardiovascular Disease and Hospital. Dr. Shafiqur Rahman Patwary is a very keen to disease management of cardiovascular disease. He is a very expert in invasive as well as non-invasive cardiac procedure. Dr. Patwary is very prominent figure in our cardiology and cardiac specialist arena. He is a very much clinician, very important clinician, and very important fellow, European Society of Cardiology, American College of Cardiology, and since 2008. And he is very much sincere and expertise in invasive procedure like CT angiogram and lots of procedure he has made in his arena. Let's welcome to our honorable speaker, Dr. Muhammad Shafiqur Rahman Patwary, sir. Sir, assalamu alaikum. Welcome to this masterclass on heart failure management. Sir, assalamu alaikum.
Walaikum assalam. Thank you, Dr. Imtiaz, for your nice introduction. And now, can I start this lecture?
Want to share, dear viewers, this presentation is very important for medical graduate. Those are already in post-graduation training course in cardiology, medicine, and nephrology, and also general practitioners are very important topics to manage heart failure management. And today's masterclass is sponsored by SK+F Limited, and scientific partner is Emazid Infoglyphosin, as well as our media partner is MediTalk Digital. Let's welcome to watch our presentation. Heart failure management is a pathophysiology of heart failure. Let's start our presentation.
Thank you, Dr. Imtiaz and SK Pharmaceuticals Limited, as well as the MediTalk media partner for arranging such masterclass on the heart failure management. And today, the lecture one, it is the most basic part of the heart failure, that is pathophysiology of the heart failure. And I welcome who are watching this program. That is pathophysiology of the heart failure. It is the basic part of the heart failure. That is, we know the heart failure is one of the important cardiac problem in the world, and that is 50% of the cardiac problem is including the heart failure. And in the heart failure, we found that there is some are heart failure with reduced ejection fraction and some are with that is preserved ejection fraction. Both of them are 50-50. And nowadays, we found that with heart failure patient, most of the patient is that is more than 50% patient is die within the 5 years. And it is one of the important disease, and it is that is more dangerous than the some cancerous condition also, as because the heart is we found that most of the disease in the heart, structural or functional, some disease like ischemic heart disease or valvular heart disease or cardiomyopathy, most of the cardiac problem ultimately they turns to the heart failure. That is it is a complex clinical condition. We found that uh, there is some symptoms and sign also we found, and this is result from the structural and functional impairment of the ventricular filling as well as ejection of the blood. And we know that during the diastole, blood is flowing into the ventricle, both right and left ventricle, and during the systole, this blood is ejected from the heart. And in both function may be impaired. And initially, we found that if the systolic function is impaired, it is that is heart failure. Now we found that both systolic and diastolic function, both together or separately, may be impaired in the function of the heart, and so we can divide it, the heart failure into systolic heart failure. Sometimes it is divided into the diastolic heart failure. Sometimes both systolic and diastolic heart failure are combinedly present. And nowadays, heart failure is most of the society of the heart failure in the world, they classify it according to the ejection fraction of the left ventricle. That according to the ejection fraction, they classified it is heart failure with preserved ejection fraction, with mid-range ejection fraction, the improved ejection fraction, and the reduced ejection fraction in the four types. Next slide, we found that the some factor which is related to the cardiac output, and mainly cardiac function. We know that heart is pump out the blood from the heart, and this blood is going to the different part of the body through the blood vessel, and this is the main function of the heart, and they transfer the nutrition as well as the oxygen to the different organ of the body. And for the transmission of this blood, this is main function of the heart is the pumping action of the heart, and they pump out the blood from the heart, and this is the cardiac output. And this cardiac output is dependent on heart rate as well as the stroke volume. If heart rate is increased, so cardiac output is increased, and at the certain limit, that is cardiac output gradually decrease. And there is a stroke volume. We found that stroke volume, this is the amount of the blood which is ejected from the heart in each contraction. That is in stroke, that is in systole, one systole, this blood is ejected from the heart is the stroke volume. And this stroke volume is dependent on the preload and afterload as well as contractility of the heart. That is, we found that heart has some venous system. Through the venous system, blood is come into the heart, and heart is contract. Then this blood is come out from the heart by the arterial system. So preload is depend on the venous return, and the afterload is depend on the arterial resistance. And contractility of the heart, that is myocardial performance, is very much important for ejection of the blood from the heart. So this heart cardiac function, that is heart failure, is mainly due to the failure of the cardiac output. And this failure, it may be related to the heart rate, that is stroke volume. These are the some factors, that is preload, upload, and contractility. And we found that if there is contractility is decreased due to the myocardial infarction or myocarditis or cardiomyopathy, that is if any muscle disease or muscle may be damaged due to ischemia or heart attack, then stroke volume is reduced due to the contractile function is the decrease. If we found that the afterload, if afterload is increased, like systolic blood pressure or coarctation of the aorta or any other condition where the peripheral resistance is increased, there is afterload is increased, so cardiac performance is reduced, so heart failure may be occur. Next slide, we see that the heart rate. In general, we see that the higher the heart rate and higher the cardiac output. And with excessively higher heart rate, diastolic filling time begins to the fall, thus causing the fall of the stroke volume and then the cardiac output. And so that is cardiac output is reduced, and ultimately, if there is a heart rate is increased, like atrial fibrillation with fast ventricular rate, supraventricular tachycardia with very fast heart rate, like ventricular tachycardia. If in heart rate is increased, uh, simply with sinus tachycardia with heart rate is more, then cardiac output, ultimately cardiac output is decreased. And we see this from the chart that heart rate is 60, that is stroke volume is 80 ml, and cardiac output is 4.8. If heart rate is 80 per minute, then stroke volume is 80 ml, and cardiac output is 6.4. 100 per minute, it is 8 liter per minute. Is 130 per minute, it is reduced from the 8 to 6.5 liter per minute. If heart is increased further 150 per minute, then stroke volume also decrease, as well as cardiac output also decrease. So if any disease which causes the increased heart rate in the cardiac condition which leads to the increased heart rate, so ultimately after a certain limit of the heart rate, cardiac output is decreased. So cardiac performance is reduced and heart failure may occur. Next, if we see the preload, preload, that is the volume of the blood, the amount of the fiber in the myocardium is stressed in the ventricle at the end of the diastole. That is, during the diastole, heart is relaxed and blood is comes from the venous system into the left ventricle, and myocardial fiber is stressed, and then they receive the blood in the heart. If any condition which reduce the stressing power of the myocardium, that is myocardial fiber stressing power is reduced by any condition, or blood volume is increased from the venous return in the increase, at the certain limit, ventricle cannot cooperate. That is, it cannot that is compensate such amount of the blood. And we see in the physiology, that is Frank Starling law, is greater the heart muscle fiber are stressed because of the increase in the volume, the greater their subsequent force of the contraction, বাট অনলি আপ টু এ পয়েন্ট। একটা নির্দিষ্ট পয়েন্ট পর্যন্ত আমরা দেখি যে হার্টে যতটুকু ব্লাড যাচ্ছে সে কিন্তু সেটা রিসিভ করতে পারে। এর বেশি যখন যাবে তখন হার্ট কিন্তু রিসিভ করতে পারবে না এবং আস্তে আস্তে হার্ট ফেলিউরের দিকে চলে যাবে। সুতরাং এক্সেসিভ প্রিলোড, এক্সেসিভ স্ট্রেস, ultimately it reduce the contraction and reduce the stroke volume and cardiac output. So if the preload is increased or muscle strength is not cooperate with this preload, then cardiac output is decreased. So heart failure may be imminent in this condition. Next, we found that if the cardiac output and diastolic volume, that is during the diastole, if end diastolic volume is increased, at the certain limit, cardiac output is increased. After that, the cardiac output is gradually reduced. So we found that some condition like the vasodilatation in the peripheral region, like thyrotoxicosis, or some arteriovenous fistula, there is a blood is shifting from the arterial side to the venous side rapidly. So venous return is more and cardiac load is increased. In this condition, we found that the heart failure is occur. It is due to the increased preload and heart capacity not cope with this blood, so cardiac output is reduced and heart failure occur. If we see the afterload, that is resistant against which the ventricle pump, excessive afterload, difficult to the pump the blood and reduce the cardiac output and stroke volume. When heart is pumped, there is the blood is come out, and this blood is going through the arterial system. And we know our arterial system have a certain normal blood pressure. That is, we know that systolic blood pressure is 120 millimeter mercury, diastolic 80 millimeter mercury, less than 40, 140, it is normal, less than, and that is 90 millimeter mercury, diastolic normal. So we have a normal blood pressure. If the blood pressure is increased, then resistance in the blood vessel is increased in arterial system, then heart cannot cooperate with this high blood pressure. For this reason, heart is more contract and it need more energy. So ultimately, heart is once upon a time, heart, that is cardiac output and stroke volume is reduced, heart pumping action is reduced. So heart failure may occur. In the case of the hypertension, like also the coarctation of the aorta. Artery is narrow, large artery. So in narrow artery, blood goes through this narrow artery is required the more force through the narrow vessel, and for this reason need more contraction of the ventricle, and ultimately at the certain limit of the time this ventricle may be failed and the heart failure may occur. So after, if afterload is increased, and then there may be cardiac function is impaired. Contractility. We know that if heart muscle is normal functioning, we found that normal cardiac output and stroke volume. If heart muscle ability to contract is decreased, it is contractile power is decreased, heart cannot contract properly, like infarcted tissue. In case of the heart attack, that is myocardial infarction, no contractile strength, that is muscle is necrosed. If ischemic tissue, reduced contractile strength. If electrolyte imbalance or acid-base imbalance, there's a myocardial performance also reduced. Negative inotropic agent if used, like beta blocker. In this condition, we found that muscle contractile power is reduced, myocardial, so myocardial performance is reduced, so they may cause the heart failure. And contractility sometimes increase with sympathetic stimulation and the positive inotropic agent. In this case, we found that cardiac output may be increased, and this sympathetic activity is increased if heart, that is cardiac output is reduced, and this condition sympathetic activity is increased. So try to compensate this reduced ejection fraction by the sympathetic activity. And from this flow chart, we found that if there is heart failure, there is a decrease the cardiac output, and if decreased cardiac output, there is activation of the sympathetic nervous system, one hand, and in this way, cardiac heart rate try to increase. We know previously that at a certain limit, if heart rate is increased, cardiac output also increase. By this way, our body try to compensate the heart failure. Next, if cardiac output is decreased, decrease renal blood flow. If renal blood flow is decreased, there is renin, angiotensin, and aldosterone system is activated. If this system is activated, then arterial and venous contraction is there. So peripheral resistance, total peripheral resistance may be increased. By this way, they try to increase the increase that is after preload, is try to increase the preload by contraction of the peripheral vessel, so venous return is increased. In this way they try to cardiac that is filling of the heart may be increased. But if arterial side is contracted, there is a afterload may be increased. By this way heart failure may be aggravated, and salt and water also retain, and this way body fluid retention is there, and cardiac volume is increased, and diastolic performance also reduced, and remodeling of the heart is there. If heart failure there is, uh, if there is heart failure, that is in the area where myocardial ischemia or infarction, in this region there is a fibrosis occur, and in the other healthy zone there is a thickening of the myocardium, and myocardial hypertrophy may occur. In this way heart may be enlarged in the normal area, and there is dilatation and thinning in the infarcted area. There is a remodeling of the heart, and this remodeling ultimately leads to the dilatation of the heart and stressing of the myocardium also, and it aggravates the heart failure. And if cardiac heart failure, that is cardiac output is decreased, we found that there is a three neurohormonal system in our body is activated. One is renin angiotensin system, we know. Another one is sympathetic system, and another one is natriuretic peptide and nephrolytic enzyme system. Sympathetic system, we see previously, that is if heart failure is occur, there is activation of the sympathetic system, and they try to increase the heart rate, as well as the peripheral resistance. By this way, they try to compensate the cardiac output. And renin-angiotensin system, it causes the vasoconstriction. It ultimately it has some that is bad effect in the heart failure. And natriuretic peptide and the neprilysin enzyme, they try to beneficially effect for the heart failure patient. And natriuretic peptide, and ultimately by this way, in the heart failure patient, they try to uh, increase the ventricular filling pressure, increase fluid load, and increase arterial pressure, and they try to compensate this. But uh, during the compensation, there is some bad effect also. Like that, renin-angiotensin system is activated more. It has deleterious effect. That is, it has less beneficiary effect for the patient of the heart failure. If we see this chart, we found that renin-angiotensin system activated causes angiotensin 1 and angiotensin 2, and ultimately this angiotensin 2 causes peripheral vasoconstriction. It increases the upper load. If increase upper load over the heart is increased, so cardiac output is decreased, and it also increases the aldosterone secretion. This aldosterone causes the potassium loss from the by the kidney, and also causes fibrosis in the heart, and the salt and water retention, and ultimately edema, and increase plasma volume, increase preload, and increase cardiac work. And by this way, they further decrease the cardiac performance. So renin-angiotensin aldosterone system, by this renin-angiotensin system, uh, on the one hand, they try to increase cardiac output by the increasing preload. In the other hand, by increasing the afterload, it decreases the cardiac performance. So ultimately, net result is not good for the heart failure patient. But natriuretic peptide, it has the beneficial effect on the heart failure patient. When the heart failure is occur, it stress over the heart muscle, that is due to the increase the volume, increase the end diastolic pressure. So natriuretic peptide is released from the heart chamber, that is the ventricle, and this natriuretic peptide ultimately causes the vasodilatation, peripheral vasodilatation. So it decreases the afterload, and if the afterload is decreased, cardiac output may be increased, and it causes the diuresis, natriuresis. Ultimately, the fluid volume overload try to decrease and reduce renin release. Renin aldosterone system activity is decreased by the natriuretic peptide. So, by this natriuretic peptide system, if a patient suffering from the heart failure, they try to compensate to the deleterious effect of the renin-angiotensin system activation as well as sympathetic system activation. And we found that this is one of the enzyme, that is neprilysin enzyme. They try to break down this natriuretic peptide. If this enzyme activity is increased, it also have the bad effect on the heart failure patient. So during the treatment, we try to inhibit this enzyme by the secubitril. By this inhibition, so increase natriuretic peptide, and we found this beneficial effect in the treatment of the heart failure. And during the heart failure, by these two systems, that is natriuretic peptide and the renin-angiotensin system, by these two system is activated, and the balancing of these two systems, they try to compensate. If they compensate this is compensatory heart failure. If they cannot compensate, then it is decompensated heart failure. And some factor we found that they aggravated the heart failure. As because if a patient is suffering from the heart failure, we found that some patients are stable, some patients are sometimes repeatedly readmitted into the hospital, and some patients are during the acute decompensation, patient may die. And most common factor which aggravate the heart failure are, that is non-adherence with the medical regime, that is sodium and fluid restriction, as well as the ischemic attack, that is acute coronary syndrome, macular infarction, uncontrolled blood pressure, atrial fibrillation, or other arrhythmia. And the recent addition of the negative inotropic agent and verapamil, nifedipine, diltiazem, beta blocker, pulmonary embolism, initiation of the drug that increase the salt retention like steroid, NSAID, and excessive alcohol and endocrine abnormalities like diabetes mellitus, hypothyroidism, concomitant infection like pneumonia or other viral infection, and other cardiac problem like endocarditis, myocarditis, aortic dissection. These factors may aggravate the heart failure. And nowadays, heart failure is mainly defined by the ejection fraction. And what is ejection fraction? It is the percentage of the blood that pump out by the heart, that is ejection fraction, by each contraction. Normally it is 50 to 70%. If heart is failed, the cardiac chamber is enlarged and reduce the ejection fraction of the heart. And according to this ejection fraction, nowadays the heart failure is classified into the four groups. One is the heart failure with reduced ejection fraction, that is, if the ejection fraction is less than 40%, then 40% or equal to 40% defined, it is at heart failure with reduced ejection fraction. And heart failure with improved ejection fraction, if previously ejection fraction is less than or equal to 40%, after treatment or during the follow-up measurement, if we found it is more than 40%, we term it is heart failure with improved ejection fraction. And heart failure with mid-range ejection fraction or mildly reduced ejection fraction, that is left ventricular ejection fraction 41 to 49%, or evidence of spontaneous or a provoked increase in the left ventricular filling pressure. That means it is evident by increased pro-BNP and in the blood, or non-invasive or invasive hemodynamic measurement. That means left ventricular end-diastolic pressure or left atrial pressure or waist pressure may be increased. It is measured in the cath lab. And heart failure with preserved ejection fraction, that is left ventricular ejection fraction is more than 50%, with associated that is left ventricular filling pressure is increased, which is evident by increase that is N-terminal pro-BNP or BNP level, or in the cath lab by the evidence of the increased left ventricular and diastolic pressure by direct measurement in the cath lab. And stage of the heart failure, uh, he classified the heart failure by ejection fraction, and American College of Cardiology, they classified the heart failure in the way of four stages. That is stage A, B, C, and D. And A and B patient have no symptoms of the heart failure. A, that is, they categorize the A, those patients having the risks of heart failure. That means this patient having the some risk factor which ultimately causes the heart failure, like hypertension, coronary artery disease, or valvular heart disease. But patient have a no sign symptom of the heart failure. But this patient may turn to the heart failure at any time. And this patient is categorized as a stage A. They are in the risks of heart failure. Next, stage B, they categorize the stage B, those with the structural heart disease, but without symptom of the heart failure. A, that is the risk factor is there, but there is no structural heart disease. But B, having the structural heart disease, but without any symptom. What is structural heart disease? That is heart structurally damaged, like left ventricular function is due to ischemic heart disease, like valvular heart disease. It is that is moderate to severe regurgitation or stenosis, or any congenital heart disease. These are the structural heart disease is present, but patient having no the symptoms of the heart failure. Stage C, that is structural heart disease is there, that is left atrial enlargement or left ventricular enlargement or valvular regurgitation, involvement of the valve is there with patient have symptom of the heart failure, then is current or prior symptom অথবা প্রিভিয়াসলি তার সিমটম ছিল অথবা নতুন করে তার কোনো সিমটম আসতেছে হার্ট ফেলিউরে, এই ধরনের যদি কোনো সিচুয়েশন থাকে সেই গ্রুপের পেশেন্টকে আমরা সি ক্যাটাগরিতে আমরা ফেলি। আর ডিতে হচ্ছে তাদের হচ্ছে রিফ্লেক্টরি অর অ্যাডভান্স হার্ট ফেলিউর, যে পেশেন্টের সিমটম আছে কিন্তু সিমটম ইমপ্রুভমেন্ট হচ্ছে না, তারপর হচ্ছে গ্রেজুয়ালি ডিটোরিয়েট হচ্ছে, এই ধরনের পেশেন্টগুলোকে ডি ক্যাটাগরিতে ফেলা হয়, যেগুলো হচ্ছে ক্রনিক হার্ট ফেলিউর। এবং এই হার্ট ফেলিউর পেশেন্টগুলো রিপিটেডলি রিএডমিশন নিচ্ছে হসপিটালে, এবং অ্যাজ ওয়েল এজ সাম পেশেন্ট আর ডাই ডিউরিং দ্য ট্রিটমেন্ট প্রসেস। In the heart failure, we classify this heart failure symptom that is in a functional state, and that is the NYSA functional classification of the heart failure. We classified heart failure as a class 1, class 2, class 3, class 4. This is the symptomatic classification of the heart failure. This one is needed for the treatment purpose, and sometimes it also needed uh, uh, for the for risk stratification also need. That is, we found that if the patient have the class 1 symptom, patient mortality is less. If the patient have the class 4 symptom, there is a more chance of readmission and more chance of the death. For this reason, we classified according to the NOS functional class. That is, class 1 is the asymptomatic, no imitation of the physical activity or ordinary activity. Class 2 symptoms, there is moderate exertion a patient having the symptom like ordinary physical activity, patient complain the shortness of breath and fatigue. And class 3 is the symptom with minimal exertion, that is less than usual activity, patient appear the sign symptom of the heart failure. And patient having the sign symptom of the heart failure at rest, even patient unable to carry some small things, and also during the lying posture or sitting posture, patient complain the symptom of the heart failure, that is shortness of the breath or patient fatigueness. We previously I told that the heart failure is one of the dangerous disease, that we found that more than 50% patient die within the 5 years. That is 48% patient die within the 5 years. But some cancerous condition with the breast cancer and the Hodgkin lymphoma, non-Hodgkin lymphoma, colon cancer, leukemia, these cancerous condition we found that they have the 5 year death rate is less than 50%. So heart failure is one of the important cardiac disease which has the high mortality. So we need identification of the risk factor, those who are in the risk of the heart failure, and treated the risk factor. By this way, we prevent the heart failure. That is very important issue, as because if the patient develop the heart failure, it is most costly to treat the heart failure, as because nowadays those drugs are used for the treatment of the heart failure. That is ARNI, one of the drug, important drug. Another one is the SGLT2 inhibitor. These drugs are most costly for the patient, as well as sometimes if the patient having the heart failure with reduced ejection, patient may need intracardiac defibrillator, ICD, or cardiac resynchronous therapy is also costly. So, if you know the pathophysiology of the heart failure, that is, I try to understand, I try to explain how the heart failure occur and what is the precipitating factor causing the heart failure. And initially, I try to explain the normal, that is heart function, and what is the factor can interfere the heart failure. That is, we know that the mainly the cardiac output is the very important factor. If the cardiac output is reduced by any way, like if the heart rate is increased by the arrhythmia or by the increasing the afterload, that is hypertension, or by the other disease which causes the increase the arterial resistance like coarctation of the aorta, if any disease which increase the free load, that is like some arteriovenous communication, that means during the CKD patient we uh, create a fistula in the forearm. This fistula causes the blood from shifting from the arterial side to the venous side rapidly. This shifting may increase the free load, and some disease condition like thyrotoxicosis, they also cause the peripheral vasodilatation, septic shock, peripheral vasodilatation, they increase the afterload. In this way, that is by increasing the afterload, the heart failure may occur. Sometimes, if the contractional function of the heart is failure, this is the very important factor which cause the heart, which that is it improve the cardiac output. That is contraction power is improved. That's cardiac output increase. This contraction power is decreased. Many diseases like ischemic heart disease or myocardial infarction, cardiomyopathy, and myocarditis. It may occur due to the viral infection, like even due to dengue fever may cause the myocarditis. So myocardial contractile power is reduced and the cardiac output is decreased, so heart failure may occur. By this way, I try to understand what is the pathophysiology, what is the mechanism of the heart failure. If the cardiac output is reduced, we found that there is a three system is activated. One is sympathetic nervous system is activated. Another one is renin, angiotensin, aldosterone system. Another one is that is mm, natriuretic peptide. That is peptide system is activated, and we found that sympathetic and renin, angiotensin, aldosterone system, if activated more, there is it have a some bad effect on the patient of the heart failure. And if that is uh, natriuretic peptide and neprilysin enzyme system is activated, this is the beneficiary for the heart failure patient. And by these three system, balance of these three system, patient may be compensated state in a chronic heart failure patient. Sometimes if there is imbalance between this system, there is decompensation of the heart failure. And we found that some factor which are deteriorating the heart failure patient in a course of the chronic heart failure disease state. This factor including, we found that sometimes patient taking the excessive salt, patient taking the excessive fluid, and cannot take the medication properly or timely, and some disease process, that is hypertension that not controlled the properly, ischemic heart disease, if we not treated the ischemic heart disease properly, as well as anemia also one of the important factor which also aggravate the heart failure, that is precipitation of the symptoms of the heart failure or aggravation of the heart failure, thyrotoxicosis, hypothyroidism, and some drug like beta blocker, those who are decreasing the cardiac function, calcium channel blocker, some calcium channel blocker, that is diltiazem, as well as we found that some drug which causes the fluid and water retention like steroid and non-steroidal anti-inflammatory agent. As in by this way, there is heart failure may be aggravated. If heart failure is aggravated, uh, we found that if a patient is suffering from the chronic heart failure, if by this specific factor we mentioned here, that is acute coronary syndrome, anemia, hypertension, thyrotoxicosis, infection, as well as if excessive fluid and salt intake and the risk factor are not controlled. In this condition, chronic heart failure patient, sometimes we found that there is a deterioration of the symptom, that is acute exacerbation. If is acute exacerbation, patient having the chance of the mortality, that is chance of the death, and increase the mortality. So we try to identify the risk factor as well as precipitating factor for the heart failure in the course of treatment of the heart failure. If we treated the risk factor like smoking, hypertension, and other diseases, ischemic heart disease, as well as we identify the precipitating factor and treated the precipitating factor in this way, we may extend the life of the patient with the heart failure patient. And in this way, we treat the patient properly. So, if we understand the pathophysiology of the heart failure and what is the cause of the heart failure and what is the preceding factor of the heart failure which aggravate the heart failure, then we treat the patient properly. And now I'll conclude this two-day lecture with some few points. That is, heart failure is one of the that is dangerous or killer disease more than the cancerous condition, and it it also preventable if we know the disease or risk factor which causes the heart failure, and if we treat previously, then we prevent the heart failure. Even a patient with the heart failure, if we know the precipitating factor which aggravate the heart failure, if we treat the patient properly, if control the risk factor properly, and we may extend his life at a certain valuable period. And also there is some medication also nowadays developed, and some devices also there developed to extend the life of a patient of the heart failure. Thank you, those who are hearing and those who are seeing my lecture.
Thank you so much, sir. Dear viewers, we want to show the heart failure presentation, and today's lecture on pathophysiology of heart failure, and it's an excellent presentation. Thank you very much, Dr. Shafiqur Rahman Patwary, sir. It was excellent presentation. Almost cover up all the important topics. They are very important, necessary for pathophysiology. As we know that pathophysiology is very important regarding the any disease management, and pathophysiology is the root of the disease management process. One thing I want to uh, know, COPD is a very common disease in our country. It's a respiratory system disease, but some patients are very much worsening day by day regarding the heart failure. Those are suffering from COPD. Can you please share a very short statement regarding the pathophysiology of this disease?
COPD is the thank you. Thank you for your nice question. That is, we know that that is in the pathophysiology of the heart failure. It is very extensive, and this short period of time for this reason, I cut short these things. And we know that right-sided heart failure also there, left-sided heart failure is there, biventricular heart failure, acute heart failure, chronic heart failure, that is diastolic heart failure, systolic heart failure, both systolic and diastolic heart failure, a de novo heart failure, chronic heart failure, decompensated heart failure is heart failure, and it is reduced ejection fraction. In the COPD patient, this is very important. In the COPD, we found that is destruction of the lung tissue, as well as there is the arterial system also destroyed. And this arterial system, there is increased resistance in the pulmonary circulation. Pulmonary circulation due to the destruction of the tissue as well as the arterial. And so there is here is afterload is increased. When the afterload is increased in the lung circulation, so the blood from the heart in the right side, it is goes to the lung through the pulmonary artery. So pulmonary artery pressure is increased as because precapillary sphincter muscle there is increased, and there is resistance is increased, afterload increase, and pulmonary arterial pressure is increased. If the pulmonary arterial pressure is increased, that is called the pulmonary hypertension. And pulmonary hypertension, if increased, so right heart contraction is increased. So right heart and myocardial thickening, myocardial hypertrophy, right ventricular hypertrophy, ultimately right ventricular dilation, right ventricular failure. So if the patient suffering from the COPD, ultimately patient goes to the right heart failure. The right heart, if the patient having the right heart failure, so if right heart not properly contract, then ultimately it affects on the left heart. Left heart. And most of the COPD patient having the coronary artery disease also. As because COPD is in our country is mainly due to the environmental factor as well as the smoking. Both smoking and environmental factor also related to the coronary artery disease. So those who are suffering from the COPD, they also suffering from the coronary artery disease. So left ventricle also compromised in this patient. Already compromised right ventricle, left ventricle compromised. So ultimately, patient develop both ventricular failure. And COPD patients suffering from the repeated respiratory infection due to the some virus, for this reason need the vaccination yearly for that is for prevention of the infection. These infection also aggravate the heart failure. So in the patient suffering from the COPD, there is chance of the right heart failure, as well as the patient having the risk factor for the coronary artery disease. For this reason, patient also develop the left-sided decompensation, left as the heart failure, as well as COPD is related to the some infection in the lungs tissue. For this reason, this infection also aggravate the heart failure. For this reason, if a patient is suffering from the COPD, there is a more chance of the heart failure development.
Thank you very much, sir. It's a very well organized answer, and we already went 10:53, and it's a very great presentation and great masterclass on pathophysiology of heart failure management. And let's thanks to SK Pharma Limited as well as their brand partner Emazid Infragliflozin, as well as thanks to MediTalk Digital to arrange this program. Definitely, our viewers will helpful for this program. And thank you very much, our honorable speaker, Dr. Mohammad Shafiqur Rahman Patwary, sir. Thank you very much for joining this session. Thank you. Assalamu alaikum.
Walaikum assalam. Thank you, Dr. Imtiaz.